I was invited for these two talks at the EHA 2018 in Stockholm, Sweden. The second talk I gave, I was invited to talk about differences in the treatment of multiple myeloma, both in the newly diagnosed and in the relapse setting. So I'm born and raised in Sweden, I'm Swedish, but I practice in the United States for almost 15 years. So I have both perspectives and I have a quite good understanding for differences in access and also treatment philosophies. They differ quite a lot. So I try to shed light in this presentation on how treatment is done in the United States. As a European person for a European audience, shedding light on how we treat patients in the US. So not to tell people what to do or what's right and wrong, but to emphasize on the differences. And I think the striking differences are that in the United States, at the academic institutions, all those institutions would use 3 drug combinations in the newly diagnosed setting. There's no longer mentioning of the so-called risk-adapted treatment. That's old school and outdated. Patients would receive a proteasome inhibitor, an IMiD, and a steroid. And there are already studies looking into 4 drug combinations. And in fact, we have studies going where we are using those 3 drugs plus a monoclonal antibody. We will present at ASH in 2018. We hope to have up to 100 patients we have treated with different dosing schedules with 4 drug combinations on phase 2 trials. We already have preliminary data. It looks just amazing. So I think this will continue to challenge the field. For the relapse setting, I also try to shed light on differences and similarities. And I think the striking differences, again, are the use of 3 drugs rather than 2 drugs. In the United States, most doctors would use, again, proteasome inhibitors with IMiDs and steroids, or monoclonal antibodies with IMiDs and steroids. There's a lot of question whether you should think of 4 drugs or if there could be other types of permutations. So I shared data from ongoing studies and studies that recently have been published and tried to put some context. And then I ended the presentation talking about where the field seems to be going from an American perspective. I focused on CAR T cells. At my institution, we have just finished the CAR T cell study. We have 2 studies open. We are soon opening 2 more. So we have very many patients on the CAR T cell therapies. Also, we have many patients on bispecific monoclonal antibodies that bind to myeloma cells and surrounding cell CD3 antigens on T cells, as well as antibody-drug conjugates, where you deliver drugs right to the door of the tumor cell by having an antibody binding and dropping the drug into the tumor cell. So I try to put all these things together and try to give some direction. So that was my second talk.